Dear students, today I am going to read the lecture Basics of Anesthesiology, Lecture 2. Let's check objectives of the Lecture 2. Objective number 1, I am going to speak about main drugs for the treatment of pain during surgery. Objective 2, I am going to give you brief information about muscle relaxants and neuromuscular block. Objective number 3, I am going to talk about monitoring aspects during surgery and during postoperative period. And here I am going to give you very short information about alarms. What are alarms? So what are alarms for, and so on. Objective number 4, I am going to talk about transportation of the patient from operating room to emergency room. So in different hospitals, it is called recovery room or postoperative room or emergency room, it doesn't matter. Objective number 4, I am going to talk about handover of the patient. And objective number 6, I am going to talk about early post-operative period. What kind of complications may occur during this time. Okay, let's go to objective number 1, main drugs for the treatment of pain during surgery. Before we proceed to this objective, I would like to remind you the concept of modern multi-component anesthesia. So it can be displayed as a triangle. I mentioned to you in my previous lecture, each angle represents one component. First component, analgesia. So we use narcotic analgesics. Second component is sedation or hypnosis. We use sedative drugs. And third component is neuromuscular block. So we use muscle relaxants. Let's take a look at this triangle again. Number 1 is analgesia or pain relief. Number 2 is sedation or sleep. And number 3 is neuromuscular block or muscular relaxation. Let's talk about first component, analgesia. Analgesia can be provided in 2 ways. Number 1, through inhalational anesthetics such as Halothane, sevoflurane, isoflurane. And number 2 is TIVA, total intravenous anesthesia. So we use narcotic analgesics. I must say that inhalational anesthetics are commonly used in the USA and in Europe. In our country we use fentanyl, we use total intravenous anesthesia. So this is a special device to use inhalational anesthetics. So this model, you pour anesthetic here, through this hole you pour anesthetic here, and then you attach this model to the anesthesia machine. Here you can see there are 2 models at the moment. The one is for sevoflurane and the second is for isoflurane. They are color coded, so you cannot make a mistake. Okay, let's talk about second component, hypnosis. So for this purpose we use mainly 3 drugs: propofol, thiopental or ketamine. So patient falls asleep 30 to 40 seconds after IV injection, and then he wakes up after 5 to 7 minutes, sometimes 10 minutes. It depends. So this drug is propofol. Nowadays it is the best drug for induction of anesthesia and for maintenance of anesthesia. I mean, second component for sedation. Okay, and now I'm going to talk about third component, neuromuscular block. So this idea was taken from indigenous people of South America. They use this poison, curare poison, for hunting. And this idea was utilized by Canadian anesthesiologist Dr. Harold Griffith in the middle of the 20th century. So you can see his picture here on the stamp, on a post stamp. So nowadays muscle relaxants can be divided into two big groups. Number one is depolarizing muscle relaxants. There is only one drug here, succinylcholine. Succinylcholine or succinylcholine. It has different names. And non-depolarizing or long-acting muscle relaxants. So in our country we use Arduan. But I must say that there are many drugs. A lot of non-depolarizing, long-acting muscle relaxants on the market now. But in our country we use Arduan. Let's go to objective number 3 of our lecture. Monitoring. What is monitoring? It is a measuring of the vital signs of the patient, either continuously or intermittently. The monitoring device can provide an instant data, or it can display trends over some period of time of the condition of the patient. Monitoring may detect deterioration in the vital signs of the patient, or monitoring can track improvements of vital signs, or monitoring can measure the effects of medical interventions. We must understand that intubated patients on mechanical ventilation are usually deeply sedated and paralyzed due to sedative drugs and neuromuscular block. So if something goes wrong, they cannot respond and to defend themselves. Let's take a look at this slide. This monitoring device displays an instant data. So here you see pulse rate 60 beats per minute, blood pressure 120/80, 120/80, oxygen saturation 98, respiratory rate 20, and body temperature 36. On this part of the monitor screen you can see this data, and on this part of the screen you can see ECG, 3 leads, and pulse wave, plethysmography. So this slide shows the monitoring chart, which displays trends over some period of time. For example, patient has been staying in the recovery room for a long time, and this is his data over a long period of time. We must understand that regardless of the monitoring equipment, nothing can replace educated and skilled medical staff, doctors, nurses, in the assessment and monitoring of the patient. Let's continue about monitoring. Monitoring can be divided into 3 parts. Monitoring of drugs used for anesthesia, monitoring of the cardiovascular system or monitoring of circulation, and monitoring of the mechanical ventilation, monitoring of the circuit or monitoring of the breathing contour. It is the same. Monitoring of drugs used during anesthesia, I must say that all drugs must be labeled. If you have 4, 5, 6 syringes on the table, each syringe must have a label with the name of the drug. For example, this is atropine, this is fentanyl, this is adrenaline, and so on. Why do we do it? Because we need to avoid a mistake. Monitoring of the mechanical ventilation of lungs, or we can call it monitoring of the circuit or monitoring of breathing contour. In Russian we call it breathing contour. I must say that we must follow some standards of monitoring. There are no universal standards, but you can follow some well-established standards from recognized medical school or recognized clinics. For example, you can follow Harvard standards of monitoring if you don't have your own standards. Let's take a look again at this slide. It is a monitoring of circulation. On the right part of the slide you can see pulse rate 60, blood pressure 120/80, oxygen saturation, respiratory rate, and temperature. And on the left side of the slide you can see ECG, 3 leads, and pulse wave, plethysmography. So when we monitor ventilation, we need to check parameters of ventilations, such as tidal volume, respiratory rate, PIP, peak inspiratory pressure, time of inspiration and time of expiration ratio, volume of ventilation per minute, positive and expiratory pressure, capnography, and of course you need to do auscultation of lungs, blood gases monitoring, and monitoring of inhaled and exhaled gases. Some clinics use BIS monitoring, bispectral index monitoring, and neuromuscular block monitoring. But I must say that these two types of monitoring, BIS monitoring and neuromuscular block monitoring, are not commonly used in a clinical practice. And of course, we need to monitor the urine output. We need to check the systemic circulation by measuring urine output. Now let's talk about alarms. As I said to you before, intubated patients on mechanical ventilation are usually deeply sedated and paralyzed due to neuromuscular block and due to sedative drugs. So if something goes wrong, they cannot respond and they cannot defend themselves. So alarms are critically important to prevent potential problems to the patient. Consequently, mechanical ventilators have many kinds of alarms to ensure all these events are detected quickly. However, there are 4 types of alarms which are universal to all types of lung ventilators. Let's check. There are 4 types of alarms. Number 1 is high pressure alarms, B, low pressure alarms, C, volume alarms, and D, malfunction alarms. High pressure alarms are activated if there is a problem in the circuit, in the breathing contour. For example, obstructed endotracheal tube or kinked endotracheal tube, or problems with filter, or the patient has increased pressure inside the chest, for example, pneumothorax. High pressure alarms are also set to protect the lungs from potentially damaging pressure in the circuit. If the high pressure limit is reached, the ventilator immediately stops inspiration and cycles to expiration. Usually, there is a default limit on the ventilator set around 40 centimeters of water. So when high pressure limit is reached, the ventilator stops inspiration and cycles to expiration. Second alarm is low pressure alarm. Low pressure alarm is also very important, so it may indicate on disconnection of the circuit or hole in the tubes and or failure to ventilate. Volume alarms, high and low volume alarms can indicate problems with ventilation as well. It is important, therefore, to set alarms limits on high and low volumes, so these changes can be rapidly identified and corrected. And the last type of alarms are malfunction alarms. They can indicate on problems with power supply, problems with gas supply, problems with battery failure, and so on. So as you can see from this slide, malfunction alarms are alarms related to problems with equipment. Needless to say that failure of gas supply, especially oxygen, can result in disaster. It can result in the death of the patient. So all ventilators have a critical alarm for such situation. So when the surgery is over, we need to transport the patient from operating room to emergency room. So we move to objective 4, transportation of the patient from operating room to emergency room. During transportation of the patient, 50% of them have the risk of hypoxia. During transportation of the patient, the doctor anesthesiologist must have ambu bag and pulse oximeter. It is recommended. And the doctor anesthesiologist must escort the patient according to monitoring standards. He should not delegate this work to other people. So it is better to keep the endotracheal tube en route during the transportation. And during the transportation of the patient from operating room to emergency room, the patient can breathe spontaneously or with mechanical ventilation with ambu bag. And now objective number 5, handover of the patient. In the emergency room, the doctor anesthesiologist must check again patient's vital signs such as blood pressure, pulse, SpO2, urine output, and other vital signs. And also he must pass all information regarding type of operation, any problems during the operation, and other relevant information to the doctor on duty in the emergency room. So both doctors must input all data into the patient's file and sign up. The emergency room must be equipped with all equipment for urgent medical help. For example, intubation kit, drugs, suction machine, oxygen supply, and so on. So we gradually came to our last objective, objective number 6, early postoperative period. So when we talk about early postoperative period, we usually mean first 24 hours The emergency room is the best place for the patient to recover, and emergency room should be located in close proximity to operating room. So if something happens in the emergency room, you can take patient very quickly to the operating room. And all equipment for urgent medical help, such as a resuscitation kit and other equipment, must be ready for use. And all equipment must be checked regularly, every day, once a week, once a month, and so on. You need to keep checklist. So once a month you need to do internal audit, and once in 6 months you need to do external audit. But it is only an example. It depends on SOP of your clinic, standard operational policy, or SOPP, standard operational policy and procedures of the clinic where you work. The doctor anesthesiologist must be in charge of the observation of the patients in the ER. And there must be specially trained medical staff, nurses, doctors, and so on in the ER, who must observe patients after surgery. The first 2 hours are potentially dangerous for the patient. Why? Because there are many complications during the early postoperative period. I will give you only a few examples. The most common complications of the early postoperative period are respiratory depression, bleeding, low output syndrome, postoperative nausea and vomiting, and so on. Just few examples. Respiratory depression can be caused by diminished reflexes. Since the patient's reflexes are diminished, he can develop apnea and acute respiratory failure, or acute respiratory failure due to residual effects of narcotic drugs and muscle relaxants. Bleeding may occur as well. It is quite obvious. If you cut tissues, they bleed, and if you don't stop bleeding properly during the operation, you may have a complication during the post-operative period. So low cardiac output syndrome is also quite common, especially after long surgeries. So there may be many reasons for this syndrome. Reason number 1 is fluid imbalance. What does it mean? If, for example, patient lost 1 liter and you refilled only half a liter, so he will have a fluid imbalance. So number 2 reason is a mechanical ventilation can cause preload decrease. Also, retention of water in the interstitial space may occur or can occur, and so on. The pain from the site of operation, for example, chest or abdomen, can severely limit effective breathing movements of the patient's chest, and consequently, in the long term, insufficient breathing can lead to formation of atelectasis, inflammation, and then progress to pneumonia. Just to remind you that atelectasis is a partial or complete collapse of lung. PONV, postoperative nausea and vomiting, is also very common during the early postoperative period. So how we can avoid PONV? We can avoid it by using proper premedication and administration of metoclopramide before surgery and after surgery. And this is the last slide of my lecture. So you can see my email here. If you have any questions, you can write to it. And also, please follow me on my Facebook and Instagram. Check my posts. Thank you very much for your attention. See you next time. Have a good day.